Hey, doctor, I was wondering we could talk about ketamine. This is a thing that's becoming, more people learning about it. Talk to me, tell me about it. For sure. So ketamine is a pretty interesting molecule. Um, it was, I believe it was made back in the 1960s at first. It was synthesized as a derivative for anesthesia, actually off of a molecule called PCP. So anybody who knows about PCP, um, has kind of for good reason, it has a bad rep. So PCP is essentially a street drug that makes people dissociate, and it causes them to come into the emergency. From my perspective as an ER doc, it causes them to come into the emergency department combative and requiring sedation and all sorts of stuff. So, and that's part of the reason that they actually couldn't use it for anesthesia back in the day. It had too many side effects. When people came out, like they would have all these emergence phenomenon. It's just a dangerous agent. And so there was some work done on creating derivatives of that molecule. And one of those derivatives that they came up with was called ketamine. So ketamine is a really interesting molecule because unlike other anesthetic agents that we use in the emergency department and in the operating room, ketamine works in a different way. So typically, when you induce anesthesia in a person, what you're generally doing is you're taking a medication that will depress brain activity. So you're basically slowing the brain down. And ketamine works a little bit differently. It actually causes the patient to dissociate from their immediate experience. So there's kind of a threshold effect where, with increasing doses of ketamine, you may be experiencing an uncomfortable phenomenon. Like, for example, if you break your arm and have to come into the emergency department to get your shoulder set back in, or like to get your bones, set back in place and splinted, you may still be aware that you're experiencing pain, but you're not really particularly bothered by it. So it's almost like you're observing yourself from the outside. So that's kind of the backstory of ketamine. And then up through the 70s, maybe a little in the 80s, and then especially in the 90s and early 2000s, they started asking the question, first in animals and then in humans, can ketamine be used for psychiatric purposes, particularly for depression, anxiety, PTSD. The first experiments were done in animals, showing that animals would exhibit decreased depressive symptoms when they were given ketamine. And then some of the early trials were in like the 1990s, early 2000s kind of time frame in humans, where in fact, after dosing with ketamine a few times, people would report decreases in their depression, and this was measured across depression scores. And the interesting thing about ketamine is that the effect tended to persist. At first, you would see it persisting for a couple days, maybe a week, and then the later trials actually showed that the antidepressant effects would persist out to like a month. So this is pretty quickly gaining awareness in the medical community as a promising agent for depression, potentially anxiety, potentially PTSD. That data is a little shaky.
That was that was always wondering. So, how aware is the medical world in general of the positive effects of ketamine in relation to all those types of things, like the things you just mentioned: PTSD, depression, anxiety, etc.
Yeah. Well, I think there's two things going on in the medical community. I think there's growing awareness that ketamine is a therapy for depression. I think that there's concern in the medical community that ketamine is overhyped, and there should be concern because a lot of things do get overhyped at first. I spent a long time reviewing the literature for ketamine. I think we have really solid data that it's a great agent for depression. It actually can heal the brain through neuroplasticity. It can increase dendritic spines. Um, but I don't think the medical community is really aware of its potential quite yet. We also don't have long-term data on ketamine. So like, we know it works like up to a month or so. But what happens what happens past that time, like a year out, 5 years out? Are people do people return right to baseline? Like, we don't really know about that yet. I think part of what's going on too is for a long time, the medical paradigm that you're taught in medical school is that depression is a neurotransmitter imbalance in the brain. So there's the whole serotonin model. You don't have enough serotonin. It's surging throughout your brain. And it turns out that, at least the evidence that we have right now, that is not an adequate model to explain depression. And we can go into that model if you want. It's a really interesting mechanism for how depression occurs in the brain. Stress.
I think it'd be great. So I'm interrupting on, but I will.
Okay, put a caveat just because it's important that people know. Just because our underlying paradigm of depression as a neurotransmitter imbalance was probably wrong, does not mean that drugs that modulate serotonin don't work. So that needs to be clarified, because I hear in a lot of podcasts that, we were wrong about the serotonin model, therefore serotonergic agents don't work. And that's actually not the case. What is the case is that SSRIs, SNRIs, which were kind of on a combo of the serotonin norepinephrine system, they do work in about 20-ish, maybe 30% of patients. And then like maybe another 30-ish%, they kind of work. And then for maybe another 30% or so, they just don't really work. Those agents have a lot of side effects. And that's really important to consider, and especially if someone has depression. And the key also is they take a long time to work. So I just want to make people aware of that, because ketamine is not a first-line agent for depression. And so it's still important to make sure you're evaluated by a doctor who knows the pharmacology really well.
Let's say you're on another medication for depression or anxiety, like, for example, venlafaxine or Effexor for anxiety, or whatever for depression. Is there so many? As a medical doctor, would you prescribe ketamine and keep them on their other medication for a while? Is there any dangers in can they interact with each other in a bad way, a good way? Do they taper off the original meds eventually?
That's a fantastic question. There are some. So as an ER doc, I don't prescribe these, on an ongoing basis. I would be wary of mixing medications for patients in general, and unless there's really close follow up. There's also not really that much data. There are some of the trials that looked at ketamine, if I recall, were looking at a combination of ketamine and antidepressant therapy that the patients were already on. But I think that the short answer is we just don't have enough data yet. There are important side effects of ketamine that theoretically, maybe like you could say that there's a theoretical risk with other agents as well. Were essentially like seizures, that kind of stuff. Like, it was important for people to be aware of. So whenever you combine two pharmacologic agents, there's not just an additive risk. You have to think about maybe a multiplicative risk of side effects.
All right. So I'm thinking, I know in my life, and that most of us probably know people who have PTSD of some sort from something. Maybe they're a veteran, maybe they had something as a child, or just something in their life that happened where it just triggers, something can trigger them, or many things can trigger them into this high level of anxiety, fear, panic. First of all, how do you describe or define PTSD? If there's a succinct way to describe it. And then is that a network of neurons in the brain that's wired together from repetitive experiences maybe that are traumatic? And how does ketamine work on that?
Yeah, so great question. So PTSD does have a particular diagnosis in psychiatry, and I'm a little rusty on it's been a while since I was on my psychiatry rotation in medical school, maybe 7 years or something like that. There's a spectrum between a stress reaction and then an abnormal reaction to stress, and then PTSD. But essentially, it boils down to PTSD being a maladaptive learned reaction to stress. is in essence what PTSD is. That's not the technical definition. There's a time frame and all that. But yeah, certainly the neurons that fire together tend to wire together. You know, of all of the, we have solid data on ketamine's ability to treat depression. Pretty solid data on its ability. It's pretty good data on its ability to treat PTSD, but it's not ironclad, that's for sure. So like over the next 5 years, larger clinical trials could actually show that maybe ketamine is not effective for PTSD. But right now, I think they're all pointing in the right direction. It's looking promising.
But it sounds really interesting because when we think about this neuroplastic potential of the brain, I've talked with our friend Don a lot about this, and a lot of people. It, I'm no exception to the neural pathways that are like my super highways. That some of them used to be really negative and self-doubt, not believing in myself and this and that. But I love the idea that perhaps it can help enhance neuroplasticity of maybe new on-ramps to develop a superhighway of something better, more positive, more reasonable maybe.
Yeah.
Because like PTSD, I'm kind of getting, doing this, but two people can be in the same place and experience a thing that happens. One person doesn't bother them at all. The other one sets them totally off because that's a trigger from their past or reminds them of something, which could be seen maybe as unreasonable to somebody, but to them is completely, this is the way it is for my brain and I just can't help it. I guess I'm trying to say, I like the idea that ketamine can enhance neuroplasticity.
For sure. And it does it. It's probably the most fascinating part about ketamine is how quickly it does it. So maybe actually what would help to kind of illustrate this is going into the mechanisms of how abnormal neurologic patterns develop, like in depression, for example.
Yeah, that'd be interesting.
So we're starting to understand depression more as an actual disease, a pathology, rather than a collection of symptoms like I don't feel great, Some people, as you indicated, are more prone to depression, maybe 20-30% of people or so. And if I recall, people check me on this, I believe it's VAL66, and that is a mutation that affects the BDNF receptor.
Oh, wow.
And it makes people a little more prone or more vulnerable to getting depression.
Okay.
And it has to do with neuroplasticity. So when you look at the brains of individuals who suffer from depression, they have a couple things going on at the global level and at the microscopic level. So at the global level, they have decreased connectivity between the frontal lobe and the limbic system. So there's decreased what's called functional connectivity between those two areas. They are not talking to each other in the right way. They also tend to have atrophy in some of those areas as well. And whenever you see a pattern of atrophy on like an MRI, you start to think, is there neuronal cell death, neuronal cell atrophy? Is it glial cells? We don't really know. We just know the volume is decreased. So then going to the microscopic level, what's going on in these areas? So when we examine post-mortem autopsy dissections of humans and also animal models of depression, probably one of the most profound things you can see about depression is that what are called the dendritic spines on the neurons. These are the buds that receive input from upstream neurons. These are like the receivers of information from upstream neurons. People with depression don't have as many of them.
Oh, wow.
They're atrophied and they literally shrink. So imagine like a tree with Christmas lights going up it. So the neuron has a cell body. It has an axon that transmits signals, and it has dendrites. And dendrites are the tree branches that receive signals from upstream neurons. And kind of speckled on top of those dendrites are dendritic spines. Those are like the Christmas lights that are wrapped around the tree. So in individuals with depression, they don't have as many of those. And you can see this really dramatically on microscopy. What we know is that when we give an animal ketamine, an animal model of depression that has reduced dendritic spines, when we give that animal ketamine, 24 hours later, if you do a dissection, those dendritic spines are restored to completely normal. You can't tell the difference between the ketamine restored dendritic spines and the control animal dendritic spines.
That's amazing.
Yeah, so it's neuroplasticity, immediate effects. And it's thought to be due to a couple different mechanisms. One is a neuronal related mechanism, and also that ketamine might actually stimulate the BDNF receptor, TrkB. So ketamine may actually be stimulating this receptor that's like a growth, like almost like a miracle grow receptor for neurons. So why would someone with depression have reduced dendritic spines on neurons? Well, it turns out that an emerging model of depression is, in fact, has to do with neurotoxicity. And the model is basically that stress causes abnormally high levels of things like cortisol. And we know that if we expose hippocampal neurons to cortisol, that they atrophy.
Well,
So basically the model right now that we're, first of all, depression is multifaceted, but an important part of its pathology is probably stress translating into hypothalamic pituitary adrenal axis dysfunction, increased cortisol, and neuronal atrophy. And the idea right now is that ketamine can probably rescue some of that and restore it back to normal levels.
that's really interesting. Just two thoughts I'm having. One of is totally it's related but not really. I learned from Dr. Ellen Langer, Harvard. I didn't realize that each neuron in the brain that are connected one to another has like 500 to 1,000 connections. Just this huge number of connections between two neurons. So I just wanted to say that because I think it's fascinating. The other thing is this whole thing about cortisol, cortisol overloads, stress, and how it can cause problems with fat, visceral fat, according to Dr. Robert Lustig, Dr. Sean Amaro, but also brain atrophy, especially hippocampal. Now I immediately think of Alzheimer's. I think of dementia. I think of Alzheimer's as a form of dementia that, sheesh, all these different things that can affect the brain and in positive and negative ways. I mean, chronic stress is really bad for the brain.
Yeah, for sure.
Horrible.
Cortisol is important. We need it.
Right, we have to have.
If we don't have it,
We don't have it.
we need a few bursts of it. But
Yeah.
high levels of cortisol long term.
Yeah, no, right? No bueno. Yeah. So, like cortisol, when we look at the sleep-wake cycle, I'm going back to Dr. Walker, Why We Sleep, Matthew Walker, I think. In the morning, when we wake, we take in light, especially from above, the way it hits our lower receptors in the lower part of the retina, or pupils retina. It stimulates cortisol production, and it sets us up for this 14 to 17 hour wake time. But that's like your get up and go, get you through the day cortisol. Do we need cortisol after that throughout the day, or is that pretty much like it? Just here you go. Here's your morning dose. How's it work?
Yeah, in fact, in the hospital, on occasion, we'll give someone basically sort of like a mimetic of cortisol to help them get through certain acute conditions. So
we're talking about,
we need it. Yeah.
okay, so as we're talking about ketamine, like, does that have any regulatory effects on cortisol? For example, it just there's a side effect. Good question. If it would regulate and cause diminished in a time where you might get stressed out from something during the day, but the ketamine keeps you down. I wonder if the cortisol go down too.
Yeah, that's an interesting question. And I don't know if those experiments have been done, but I can answer it from a theoretical perspective. So if let's say ketamine has some efficacy in anxiety, those data are pretty questionable. I just don't think we have enough data to say yes or no, but let's say hypothetically that ketamine maybe could help anxiety. Well, if you can improve someone's anxiety on a day-to-day basis, they're probably going to have improved levels of the cortisol on a day-to-day basis. So even if ketamine is not modulating cortisol release directly, I would imagine that it's going to be efficacious for anxiety in general. That's probably going to modulate cortisol somehow.
All right. So regarding ketamine, 3 thoughts in my mind. Is it a controlled substance, if you will? Is it an addictive type of thing? And can people overdose on it?
Well, ketamine, I think this gets into just some dangers about ketamine. So the dosing here is important. Typically, these clinics that are doing like IV infusions of ketamine are doing 0.5 milligrams per kilogram.
So they're talking way less than anesthesia.
Well, actually, interestingly, usually to like reset someone's arm into place, for example, if they like dislocated their shoulder, we'll give anywhere from like 0.5 to 1.5 milligrams per kilogram. So that would be like if you're an 80 kilogram human, that would be like 40 to 80 milligrams IV. So just hold on to that number for a second, because that's like 0.04 grams. Recreationally, people are using way higher doses of ketamine, like a gram to like 5 grams. I've even seen reports of up to 9 grams.
Oh, wow.
So recreational users it's a whole different world of dosing. There are some concerns about neurotoxicity of ketamine, like when you totally overdose like mice for a while on ketamine, they can actually show signs of neurotoxicity where like just whether it's the excitatory toxicity in the brain, it causes their neurons to atrophy, brains to shrink, and all that stuff. And we see that with ketamine abusers as one. But these people are like using 1 to 9 grams every day, as opposed to like 0.1 gram or like 0.0 point. It's a difference. Yeah, it's a huge difference. So but it is important. So like other things to think about with ketamine, it can cause seizures in some people. I've seen that maybe once or twice. It can cause something called a laryngospasm, which is rare but scary. It tends to occur if you give it quickly, which hopefully is not the case in most clinics. It tends to occur with higher doses too. It's basically where the airway starts to close up. So any clinic, if I'm someone who's looking at ketamine therapy in a clinic, I would want to know that this clinic has equipment to deal with any complications like respiratory issues, that they have the ability to go all the way to intubation if they really needed to. And I'm not so sure that all the clinics that are doing this do have those pieces of equipment around. What else? Elevated heart rates, elevated blood pressure are pretty common. Those tend to be transient, could be problematic for some people. There's a whole list of side effects, but those are like probably the main ones that I think about.
So let's say someone is prescribed ketamine for a therapeutic, depression, whatever. How are they receiving that? Is that a pill, an injection? How often? Daily, weekly, monthly?
Most common right now is they're getting it infused via IV. Like 1 time a week. There's really no standardized dosing at this point, like standardized frequency of dosing at this point.
How long does it take? You go in to get your IV, and
So it's kind of
you have to go slowly, right? They don't want to go too fast.
Yeah, it can be an all day kind of event because you're still kind of loopy after the fact.
Okay.
Yep.
Really interesting. I've been wanting to talk about ketamine for a while now because I know if it's not on the forefront already, it's close to it. I think we're going to hear more about it. Would you say so too?
Oh, for sure. Yeah. And there's some drugs that are spinning off of ketamine as well. Like esketamine is a certain enantiomer of ketamine. And it got conditional approval for intranasal use for depression in a supervised setting. But I think in general, yeah, what we're going to probably start to see is that pharma companies are going to try to leverage the neuroplastic effects of ketamine without necessarily the dissociative effects. And it's unclear right now whether the dissociative effects of ketamine are really needed, like those psychedelic kind of properties, right? Can we capture all of the antidepressant effects of ketamine just through the BDNF neuroplastic kind of pathway? I'm not really. I don't know if anybody really knows the answer to that quite yet.
One of the things that this is kind of like really old news at this point, decades probably, is that a long time ago, it was believed by the medical world that we're born with a certain number of brain cells. You just have to learn as much as you can while you're young because you're not going to be able to learn when you get older. Thank the good Lord that's not true. Because
For sure.
it took me to like 50-something years to finally start to get my life together and actually do something productive. And I've been learning a lot every day, like today with you. So because of the brain's ability to mold this stuff, be neuroplastic and take in new information and learn new habits and movements and skills and work and all that. I love it. I love it. Do you have any takeaway message for our viewers?
Well, regarding ketamine in general, I just think it's fascinating. I think as an ER doc, the reason I'm so fascinated by it is it's this agent that we tend to sedate people with ketamine, and now it's got this whole other use. So it's just so fascinating to me. Um, but in general, you want to do things that keep your brain healthy, and neuroplasticity is an important part of that. That's probably part of the reason why, for example, exercise is so important and so effective in things like depression. Yeah, when you exercise, you get a huge burst in BDNF, and that helps you to not only just maintain healthy neurons, but also wire new connections, uh, process emotions in different ways. Adequate sleep is super important for neuroplasticity and adaptation as well. Ketamine is just just like any other medication. It's a medication, and it really should be used in that kind of setting, like lifestyle first, and lifestyle um, synchronously with medication use. I still think there's a really important role for despite how much bad press they're getting, I still think there's a really important role for the more traditional antidepressants, noting that they only work really well for kind of a minority of people, but there's an important role there. Um, Neuroplasticity is the takeaway, though. Healthy lifestyle patterns that promote brain health
Yeah,
and neural growth.
yeah. Don't eat crappy food. Stay away from it a lot. And maybe indulge once in a blue moon, but not every day, all day. Keep moving. Because when we move, I mean, the elevated heart rate and contractures of muscles, they do things like, it's like a neural pharmacy we have. It's like our body is a human pharmacy. And yeah, well, all these positive things get created and start flowing through your body and in your brain. And it's just so healthy. And we were talking last night about people tend to move better when they're, learn better when they're moving.
Yeah.
And I mean,
Kinesthetically.
we've done that for a long time. I never met anybody who can run on a track and read a textbook at the same time, but you're the man. No, seriously, it's really impressive.
Those were the days.
But, walking on a treadmill, trying to read, or for me, it's audiobooks, or whatever you do, I do a lot of audiobooks when I'm like walking, running, especially when I'm biking. But I know I learn better. You ever have this happen when you're running or walking, like you're by a particular landmark? Maybe it's the clock across the street, but you heard something simultaneously at the same time. And I associate those things, especially if it's one of those highlights that is going to help me to help other people better or help myself. I help myself to function better. Oh, yeah, when I was by the clock. In fact, I could be going by the clock again, not be listening to that book, but still remember it every single time. And that's part of my learning process.
Yeah, it's like we're built to remember concepts and things and places to kind of like together. We're hunter-gatherers, foragers. It's important to remember where you find good things, if you're out looking for food. And I think there's a lot to be said about, especially for like students out there, medical students. If you're it works for some people to just sit at a desk all day, and just read the textbook and do flashcards and stuff. But it never did for me. And so, but yeah, I've always admitted I'd be a sandwich. You always just, exactly. Yeah. So I just found that like getting out, walking around while you're learning stuff, whether it's audiobooks, flashcards, it really helps. Like, and then I would notice when I would sit down and take the test, like a board exam or whatever it was, I would get to like a certain question about maybe a certain, mechanism for a drug. And I'll be like, oh yeah, that's like where I was running by that stop sign. That corner. I got it.
I do the same thing. I have the same thing, whether it's driving, running, bicycling. Well, this has been great.
Yeah.
I think, if you don't mind, can you just tell people where to find you and how they can support your podcast? These are a really great podcast. It's YouTube, Spotify.
Sure. Yeah. Thanks. It's Sterling ND PhD. So just the word Sterling ND PhD. Probably there'll be a link in the description.
Yeah, we'll put links in the script for both of them.
On YouTube, Spotify, Instagram. YouTube and Spotify is most of where my video content is.
So if you, go down into the description, check out, and, the best way to support is really subscribe and like, share, subscribe. YouTube and Spotify. It helps him, helps me, and we really appreciate you watching and listening. Thanks, buddy.
Thank you.
We'll do it again soon, for sure. See you later, folks. Thanks for watching. Bye-bye.